again thanking Matthew and Providence team for giving me an opportunity. So today the topic assigned to me is case-based discussion of using glucometers in clinical practice. So I would like to introduce the topic and then end up with few case-based discussions. So as you know, intervention studies and recent trials have evaluated the positive impact of tight glycemic control supported by self-monitoring blood glucose and also on the blood glucose level and complications in type 1 and type 2 diabetes. And after that, intervention trials and recent trials have come out, the scientific society had developed guidelines and recommendations on how to define and optimize the self-monitoring blood glucose prescriptions. So the idea came from the DCCT trial, especially for type 1 diabetes. So when the DCCT trial was designed, self-monitoring glucose was a full part of the tight control strategy and helped to guide insulin treatment. So there were two arms, conventional arm and the intensive arm. So the intensive arm, basically they had daily self-monitoring blood glucose, pre and postprandial glucose monitoring, monthly HbA1c. So the daily insulin adjustments were based on self-monitoring blood glucose, whereas that was not in the conventional arm. It was either urine testing, not specifically used for insulin dose adjustments. So you can see the end result here. The patients who were on intensive arm had reduction in the retinopathy 76% and microalbuminuria reduction of 34%. Then that is type 1 story. Then what about type 2 story? If you look at the UKPDS trial in type 2 diabetes, as you can see, that the main conclusion concerned the reduction of complication of type 2 diabetes by improving blood glucose or blood pressure control. So 1% reduction in HbA1c of type 2 diabetes were associated with a 37% decrease in microvascular complication and 21% risk reduction of type 2 related death. So now, what about so that was HbA1c reduction, but whether this HbA1c reduction by monitoring of self-monitoring blood glucose will achieve a better results. So this was the study for patients the main question when we say about self-monitoring blood glucose is patients not on insulin or not on intensive insulin therapy, that patients on oral hypoglycemic agents, or is it cost effective is the question. So for this, we had a meta-analysis of 9 trials with type 2 diabetic patients, 6 months follow-up with self-monitoring blood glucose versus control. So you can see the mean decrease of HbA1c was 0.3% in HbA1c compared to control group. Good number studies. So patients were around 1,261. Then there was around another group study where a meta-analysis of 2 trials with newly diagnosed type 2 diabetes, 12-month follow-up. You can see an HbA1c reduction of 0.05%. So it is shown that even in patients, now again, the meta-analysis of trials who are not using insulin, HbA1c reduction of 0.4%. Then even we have a Cochrane database analysis, meta-analysis type 2 taking oral agents or once daily basal insulin, again, there was HbA1c reduction. So from these trials, clinical trials have demonstrated the efficiency and the value of self-monitoring blood glucose. So the interventional studies have demonstrated the benefit of tight glycemic control and marked a breakthrough in the management of diabetes. So type 1, we have DCCT trial, and type 2, we have UKPDS study, which both have demonstrated. So from these, we can conclude that self-monitoring blood glucose now plays a key role in the achievement of better clinical outcome and prevention of long-term diabetes complications. So now we are going from evidence-based medicine to guidelines. So if you look at the ADA guidelines or any guidelines as far as the self-monitoring blood glucose, it is an integral part of diabetes management program. And self-monitoring blood glucose protocol should be individualized according to patient's profile. There is no point in measuring self-monitoring blood glucose and without not taking any action. So as the point I would like to emphasize is, it should be a combined effort from both the patient as well as the concerned doctor. So for the self-monitoring blood glucose to be very effective, the patient education is the key important for the self-management. So if you look at the self-monitoring blood glucose, the major society, all are involved and all of them suggest focus on the self-monitoring blood glucose. So you have EST guidelines, you have IDF, ADA, ISPAT, NICE guidelines, and even we have the RSSDI guidelines for self-monitoring blood glucose. So what do you mean by self-monitoring blood glucose? It's basically a valuable tool to the use of HbA1c in achieving glycemic control. Rather than difference between the HbA1c, it provides the real-time feedback, detects abnormal glycemic profiles. It facilitates the appropriate medication management, like when there is hypoglycemia, we can adjust the dose, acts both as an educational and a motivational tool for the patient. For example, when you are taking a specific food, say how much is the glycemic exertions can be analyzed by doing a self-monitoring blood glucose. So self-monitoring blood glucose should be done at different times of the day. So the classical one is the 7-point we do, that is fasting every pre-meal and post-meal, and at 3 a.m. to look for nocturnal hypoglycemia. So this is the classical 7-point self-monitoring blood glucose. So if fasting and preprandial and is controlled, but HbA1c is above the target, always you should monitoring the postprandial glucose. It predicts the accurate prediction of glycemia. It detects hypo and hyperglycemia in detail. It also provide feedbacks to the patients and clinicians on therapeutic lifestyle or anti-diabetic medications, which are essential for diabetic management. So it also gives, educate the patients also about dietary habits, meal-based self-monitoring, see the effects of their meal choice and portion size. Then also something about the glycemic variability. So to measure the glycemic variability, we have only two choices. One is the self-monitoring blood glucose. Second is the continuous glucose monitoring. So the HbA1c does not identify the mean amplitude of glycemic exertion. So appropriately timed self-monitoring blood glucose can detect the glycemic variability. So also the preprandial and 1 to 2 hours the post-meal can evaluate the exertions. So before you starting with a self-monitoring blood glucose, what you should always be confirmed about the accuracy of your glucometers. Because as you know, you are using a capillary blood glucose. So capillary blood glucose in the fasting is almost equal to the venous plasma. But in the postprandial state, the capillary glucose can be 10 to 15% high. So the results also should be compared with them at least annually or when indicators of do not meet the self-monitoring blood glucose. Then there is something called the International Organization of Standardization, which has told the specific criteria for the glucose meter. And they specify that standard requiring that 95% of the blood glucose results should reach the following standard. That is within 15 milligram of laboratory results at concentration less than 100 and within plus or minus 15 laboratory at concentration more than 100. So this criteria needs to be standardized before you choose the glucometer, because if it is an ISO standardized, because all this criteria will be met. Now coming to few case studies. So coming to the first case, this is Mr. X. He is a 59-year-old male construction worker who lives with his family. He is diagnosed with type 2 diabetes 5 years ago after random testing. So he's basically a manual labor. He's obese. His current weight is around 91, BMI 29. So he is a manual labor. So he has a good physical activity, non-smoker. Reason for consultation is he feels very tired, especially at the end of the day after his manual. So blood sugars is fairly okay. HbA1c is 7.5. Fasting is 130. He's on 4 milligram of glimepiride, 2 tablets per day, and 1,500 milligrams of metformin. So this was his self-monitoring blood glucose. So as you can see here, he was going into hypo. So this is where one of the indications where you can use self-monitoring blood glucose when on an oral hypoglycemic agent, when you feel symptoms of hypoglycemia. So he was having evening time where he was feeling tired, he was having hypoglycemia. So these are the things, but the dosage of the sulfonylurea is too high because he is a physical laborer and he has an evening hypoglycemia. So based on this self-monitoring blood glucose, the sulfonylurea dose was reduced to from 4 milligram to 2 milligram per day. And this is what the RSSDI recommendations on the self-monitoring blood glucose says. So here you can see patient on oral anti. There are two types, that is new onset uncontrolled diabetes during acute illness and stable well-controlled diabetes. So you can tell this patient almost stable well-controlled diabetes. You can say 4 at least 4 tests in a week on a 4 consecutive days or an alternative days. Or if your patient is well motivated, you can tell 4 times per day, as we did in this patient, and we picked up the hypoglycemia and the dose of sulfonylurea was reduced. So now coming to the IDF recommendations, where you, depending upon the needs, a precise self-monitoring blood glucose can be prescribed to allow collection of specific information. This is the patients on type 2 diabetes not receiving insulin. So detection of fasting hypoglycemia, detection of asymptomatic hypoglycemia, and evaluation of the effects of treatment. So this was because this patient was having basically symptomatic hypoglycemia. Now, if you look at the evidence in SMBG in non-insulin treated patients, as you can see, the meta-analysis almost favors doing self-monitoring blood glucose. This is the Cochrane database, which showed the meta-analysis of 5 randomized control trials comparing self-monitoring blood glucose to control groups. As you can see, still it favored self-monitoring blood glucose. Even the HbA1c reduction was only 0.3% where compared with the control. Now coming to the ADA recommendations, patients on multiple daily insulin, you should do the 7-point monitoring if it's feasible, or less injection, patient using less frequent insulin injection or non-insulin therapies. You need to decide on the patient profile. Now coming to the second case, it is a 20-year-old secretary who lives with 2 children, aged 10 and 8. She is diagnosed with diabetes around 5 years ago. Current weight is at 63 kg. She does a good exercise profile, visits her gynecologist, uses intrauterine, uses a contraceptive device. So this was her current HbA1c is 8. She plans to achieve an HbA1c of 7. She end organ workup is normal. She takes regular insulin before she's on basal bolus regimen of insulin. So she has mild hypos per week, which she corrects with 15 grams of glucose. So this was her 7-point self-monitoring blood glucose. And as you can see, her fasting blood glucose is profile, and even mild postprandial glucose is also high. So based on, so this is the 7-point self-monitoring glucose profile. So based on her observed glucose reading, what I assumes is the Mr. Wise problem. So I'll give you 4 options. So one is the delta between the pre-meal and post-meal glycemia is too high. No, that is not too much post-meal glucose exertions. She has pre-lunch hypoglycemia. No, postprandial glycemia is higher after breakfast than after meal. So all these 3 criteria has been, all these 3 has been excluded. So I would say overall the blood glucose level is too high. So what we based on this, we assume that her long-acting insulin is not enough. So what I did is I increased her long-acting insulin by 4 units. So this was, she was on 20 units of glargine. So that was increased by 24. Her fasting came down. As you can see, even the post-breakfast glycemic exertions also came down. So now we have smart glucometers, which is Bluetooth attached. So if you do on the glucometer and you have the app on your phone, your blood glucose gets automatically recorded on your phone. So it's very easy to share your information with your healthcare provider. So even the glucometers is called, the machine itself is color enabled. So that will tell you whether you are in the range or above range or below range. So because as you know, within the target range is green color, above is and below is the hypoglycemic range. Now, if you look at the ISPAD, the International Society for Pediatric and Adolescent Diabetes, especially for type 1, they advise 4 to 6 blood glucose measurements are generally recommended. The frequency should be individualized in each child. Ketones should be measured if it is more than 250 and you have nausea or vomiting. And used as a vehicle for discussion of and you should also discuss with your patients about the variability, what are the causes and what are the dietary modifications you can do to improve the glycemia and also the insulin dosage, as I've shown you in the case. Now coming to the RSSDI recommendations based on the type of insulin therapy, as you can see, when you are using a basal insulin, you can do fasting blood glucose. So if you have good resources, then you can do fasting blood glucose daily. If you have limited resources that, as suggested by the RSSDI, you can do every 3 days a fasting blood glucose. So limited care fasting levels twice a week or once in 3 days can be done. And SOS is whenever you have hypoglycemia or intercurrent illness. Now, self-monitoring blood glucose based on premix or basal bolus, as you can see, they suggest 7 point if it is possible, or every day you can do, or if you have a limited resources, once you have achieved the target, you can reduce the frequency, changing it every 2 days. It is there, or at least if you have limited resources, you should at least try to do 4 times per week. Now, this is what the remote glucose monitoring concept, they have an application which provides the insightful features that helps patients take care of their diabetes control. So that will show you as a graph. You can add even to the readings. You have smart alerts, which will alert you when there is hypoglycemia. They give you test reminders, and you can even share these things with your healthcare provider, because this is basically an app based. So the glucometer will share your information to a Bluetooth application. Now coming to the third case scenario, he's a 45-year-old chartered accountant. Fasting blood sugars is 98, postprandial plasma glucose of 142. HbA1c was 8. So here you can see fasting and postprandial is also on target, but if your HbA1c is high, so he's on premixed insulin twice daily, metformin 2 grams per day. So we know from here, this is not the problem. So this was the problem, which was the reason for his HbA1c elevation. He had post-lunch hyperglycemia. So we tried to keep it at around 140 or maximum up to 160. So what we did, we added a regular insulin 6 units before lunch. We continued the same dose of insulin and metformin. So his post-lunch reduced from 220 to 158. So obviously his HbA1c came down from 8 to 7. So this is all the case scenarios which I had shown you, but there are some disadvantages of self-monitoring blood glucose. You need to do 5 to 7 point profile at least. Mid-meal and overnight variability are usually not assessed, because we do pre-meal and 2 hours post-meal and at early morning self-monitoring blood glucose. Asymptomatic hypoglycemia cannot be documented. For that, we need a continuous glucose monitoring. Additional HbA1c reduction by self-monitoring blood glucose varies from 0.3 to 0.5%. So this is the EASD guidelines, where it is very useful if the patient properly uses the data. So as you can see, it's not only measurement which is important, but the corrective action is also important as recommended by all guidelines. Even IDF and ADA almost recommend the same view. So if the health possesses the adaptive knowledge skills and preparedness, so it can be used from the from the onset of type 2 diabetes itself. So IDF says as a part of continuous education on self-treatment as a personalized care. This is same. Post-meal measurement should be measured 1 to 2 hours after a meal. So it's one of component of the diabetes management. Now coming to more practical guidelines, the NICE guidelines, which says that people with type 1 or type 2 on insulin treatment, there is no doubt routine self-monitoring blood glucose is beneficial as long as educational support is provided. Not using, not treated with insulin, it's an integral part of patient education, and it allows the effective use of medical treatment and lifestyle interventions. So even recently diagnosed with diabetes, it's an therapeutic educational program, and the results can act accordingly. So this was the, I'm sorry for the poor quality of slides, but this was the consensus statement on the International Consensus Group in 2013. The statement on self-monitoring blood glucose, as you can see, it depends upon the patient profile also, where you decide how much frequency you need to do the self-monitoring blood glucose. So concluding my talk, self-monitoring blood glucose is an integral part of diabetes therapy as a unique tool, providing relevant information both to doctors and patients. It helps to optimize the management of diabetes. It ensures patients are correctly measuring their blood glucose and support them with adapted and structured education. It also gives valuable insights to the understanding patients' glycemic variations, identify the patterns, you can detect the issues and adapt treatments accordingly, as I have shown you a few case series. So as far as diabetes is concerned, we have advanced very long away, because where we used to diagnose diabetes by testing urine. With self-monitoring blood glucose, we don't need to taste urine. We can know the diagnosis there itself. So with self-monitoring glucose, we will have a good glucose control day and night. So thank you for patient listening.